Good morning.
Good morning.
Nice to see you as always.
You too, Carolyn.
Thank you, Dr. Rosensweet. And I welcome everybody who's going to be coming up. And we have our questions, and so we can go ahead and get started. In our first question, it's one that we didn't quite finish last time, so we could just continue on with it. And what this woman is asking is, how can one get the 24-hour urine test even if she does not have a menopause method doctor? Is this possible to do? Do we need a prescription? And also, who would read it?
Yeah, this is a big topic. I want you to know that our team periodically visits the possibility of how could we make this do it yourself? Is it possible? Which would be absolutely ideal. And where we always get stopped cold is in the United States and most countries, someone's got to write a prescription.
Mm-hmm.
A licensed healthcare provider has to write a prescription.
Right.
So there's no getting around it.
Yeah.
And there's reasons why that's true. And yeah, my team and I talk about ways, but we keep bumping into that wall. Once you encounter that wall and you face up to the fact that someone's got to write that prescription, it turns out that the job becomes this of any given woman in menopause or perimenopause. Go shopping, find, do the due diligence you need to do to find some healthcare provider that is willing to support you in some way. Best case scenario is they're going to write you a prescription and that you like them and trust them. Some physicians and nurse practitioners are so open
Mm-hmm.
that they are willing to have you be a major player in the process. And the ones that are most open, they realize that they don't know much about it. And it's an opportunity for them to learn about treating women in menopause. And they'll go on a journey with you. I mean, that's exactly how I started out 25 years ago. I had one piece of knowledge that progesterone could help. And one of my patients was in dire straits, and I gave her progesterone, and she had tremendous anxiety and was actually going crazy, and the progesterone brought her all the way back. So we teamed it. Now, there's many moving parts to proper treatment of a woman in menopause. And I must say that there is a certain percentage of women in perimenopause and menopause that are pretty straightforward. And if you would read Happy, Healthy Hormones, I really laid down the roadmap for self-treatment. It was never my intention for it to be self-treatment, but the roadmap's there. Why did I do that? Because in the beginning, 25 years ago, when I started out, I didn't know anything, and there was very little knowledge available, but I had access to be able to write prescriptions, give them to patients, and explain to women, this is how bias is going to affect you. This is how low estrogen is is giving you symptoms. And this is how, if you gradually start the estrogen, these symptoms are going to get alleviated. And this is what's going to happen to you if you overdose. So patients would start low, gradually increase, alleviate symptoms, and occasionally venture into overdose as they kept on increasing the dosage, but then backing down. The process is called dose determination by titration.
Mm-hmm.
Start low, alleviate symptoms, gradually increase. And if you happen to hit symptoms of overdose, you pause, you stop, or you back down. What I figured when I wrote that book, and I was about 10 years into treating women by that time, that the hormones are going into the woman's body. She's the best one to know and understand what these things feel like. She's going to be able to make the fine-tune adjustments. I'll give her a roadmap. This is how we'll do it. And what I've discovered over 25 years is that some women, it's a pretty straightforward process.
Right.
It is not rocket surgery. But I must say, it's rather awesome to me what percentage of the time there's challenges. And primarily, it's like anything else on the planet Earth. Sometimes you benefit by the work of an by the experience and knowledge of an expert. Like I once took on the project of adding 1,500 square feet onto a house of a friend of mine. I was inventing that wheel for the very first time. The amount of challenges I bumped into with a crew, no less, and the cost overloads because I didn't know how to do it properly. I once rebuilt an engine for an automobile of mine, a Volkswagen van, no, Corvair van. My God, I was able to rebuild the engine. And it went 8,000 miles. That was fantastic. At which point it froze up and locked up and became a permanent fixture on a playground of a preschool. And then the next time I wanted to rebuild an engine, I took it to an expert, a mechanic who had rebuilt hundreds and hundreds of Volkswagen engines. And I watched him do it. He let me watch him do it because I was so curious. And I went, look at this. There's thousands of things he's known here that he does automatically. It's part of how he does it. And I didn't know it. I know I'm wandering a bit here, but there's a certain percentage of the time, and I must say it's probably over 50% of the time, that you're so much better off not having to figure this out and being in the hands of an expert, someone who's got a lot of experience in treating women and can help guide the process. That's what a healthcare provider is about in any field. You don't want to go get your appendix removed by someone who's read a book on removing appendix.
No.
You want to go to someone who's removed 500 by the time they get to you.
Absolutely. So
at least 100. And hormones are the most powerful biochemicals in our body. So you're much better off to really be able to find an expert. Now, this was all prelude to the 24-hour urine hormone test. Testing is such a wonderful, amazing part of being a physician. There's so many tests out there that are so fabulous. Yes, they're overused. Yes, they're overprescribed. But the tool of testing is phenomenal. And it's nowhere more phenomenal to me than in the world of hormones, if you choose the proper test. And I'm going to say you can eliminate all tests other than the 24-hour urine hormone test if you want the state-of-the-art best test possible in treating women in menopause. Other tests work, like blood tests. There's many physicians and pharmacists and nurse practitioners that they still use blood tests, and that's good. It can be a rough guideline. The rest of the testing, I must say, from what I know about it, what my experience is, and I'm including the urine 5-point. That's not a 24-hour urine hormone test. That's 5 different samples put on filter paper. Oh, the scientific issues with this and the inside information I have, I do not recommend that test. And I know some of the problems they're running into. Technically, yes, they would, because the 24-hour urine hormone test is the gold standard. Now, when I met up with the 24-hour urine hormone test and ordered it, after I had given up on other testing, the first thing I saw is I was looking at 15 or 20 different analytes being reported on. We were talking about parent hormones, metabolites, for the estrogens, progesterone, the androgens, and the corticosteroids. There were so many names that I barely understood there, and it was daunting. But fortunately, the lab that I used at the time had hired a naturopath to help me interpret the test results, and he was great. Shout out to Brett Jacques. I don't know that you're around listening to this, Brett, but you were instrumental. And I was so grateful that he was there, because I would test every woman once she was treated. And it took me somewhere around 50 tests interpreted with Brett before I started getting a handle. 50. And I started getting good at it probably at 150. Because it takes experience, it takes correlating it with patients, it takes knowledge of the biochemistry. So what am I saying here? I appreciate that you want to wing it and learn it yourself, but there is a line drawn in the sand between when it's time to rely upon an expert. Like
Right.
It was time for me to rely on someone who had rebuilt 100 Volkswagen engines. You don't want to get a bone set by a general practitioner. They could do it.
Yeah.
I could do a cesarean section. After all, I sat in on a few of them as a medical student, but I know enough about surgery. But oh my God, I'm the last person on the planet Earth you'd want to. No, I'm not the last person, but the level of technical expertise, training, and experience one needs to do a cesarean section is just off the charts. And in medicine, there's thousands of examples like this. Well, interpreting a 24-hour urine is nowhere near the magnitude of performing a cesarean section. So it's only a metaphor.
Yes.
But as far as someone self-interpreting a 24-hour urine hormone test, well, number one, you can't get it. You can't call up the lab and have them send you a kit.
You have to have that prescription.
You have to have a requisition from a healthcare provider. And there's 2 labs in the United States that are terrific at it. And they don't let you just order the test and get it interpreted. You need to do it through a healthcare provider. And you said a long answer, but the case I'd like to make is we're talking about the most powerful biochemicals that exist in the human body. Hormones. We're talking about 10, 20, 30, 40, 50 years of your life on Earth. If ever there was an investment to do this with excellent expertise, this is it, folks. You want to make a difference in your whole life? You want to preserve your bones and your muscles and stay away from canes and walkers and wheelchairs and assisted living facilities and nursing homes? You want to protect your brain and your arteries and your skin and your hair and your libido and your energy? Oi, Gavolt, what is at stake here?
A lot.
From my perspective, when I see how women who are in great duress or even the resurrection, simply by getting it right, well, it's what inspires me every day. I mean, when I hear a woman say, "I'm myself again," I tell you, it really is impactful. And I think this is impactful to me. when she expresses I'm myself again, I had a good night's sleep, or I'm starting to feel like myself again. When I hear things like that, it is very impactful to me. I can only imagine what it's like to the woman and the people who love her.
Oh my God, it's over the moon.
So if there was ever a thing to do with great excellence and precision, our team thinks so much of this that we have developed what we consider to be standard of care, and we're working to make it a board certified specialty because we know how much cowgirl stuff is being done out there, flying by the seat of your pants. So when I hear interpret my own 24-hour hormone test, and I realize how long it took me to be able to understand it. I loved biochemistry in medical school. Loved it. It's a language to me like English, or is to any native languages to any native speaker. It took me years and years and years and hundreds of tests to be able to get good at it. So when I hear I want to interpret my own test, I appreciate that women are challenged because they can't find providers. Though we're working on it. You should check in with the Menopause Method. We're working on it. And we're here. What we offer to any provider that wants to get expert at this, it's already exists. We've been doing it for 15 years. My partners and I have set up a training program. It's been up there for 15 years. It's in its third iteration. Humble opinion, non-humble. I think it's absolutely excellent. So if you have a healthcare provider, there's pathways that we have to help them get to excellence and do this with you. There's even pathways when you're dealing with a Menopause Method provider in our mastery program, is I'm involved in every case.
Right.
Indirectly, they consult with me in every single case when they're in the mastery program. So a long answer, gee, if I ever given a short answer, I long for the day when I give a short.
It's always good information, Dr. Rosensweet, and I thank you for that. And I think
let me take us down. The final part of this is there is an important job. And you can start out feeling hopeless about it. But it's like anything else. Due diligence is going to get you to someone competent to treat you. And we can help you be part of that, including that 24-hour urine hormone test. And even if it's a beginner, there's pathways. They got to write a prescription. That's quite what it took them to be able to write that prescription. It's really phenomenal.
Oh, yes.
And so you want to respect that. And your job is to go shopping. And if you meet up with someone and you don't feel comfortable about them or you don't trust them, let them go. And even if you run up with someone who's untrained but willing, they could do what I did. There was a time I had patient number 1, Deborah. Patient number 1. And I had a little bit of guidance, and now there's tremendous guidance available. So go shopping for a healthcare provider who can write your prescription that's open and interesting. And you may even find someone who's got some skills and some experience because they're out there. So that's your job. How do you become a good shopper? So here's a couple ways to go shopping. Go to menopausemethod.com. In my non-humble opinion, we are state of the art. We specialize in this. That's the main problem you run into is you go out there into the world of being in menopause and treated with hormones, and it's very, 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 very rare that you find someone who's specialized. And there's reasons why that happened. The whole field had a terrible body blow impact, and people were discouraged. Nurse practitioners were even discouraged to treat women with hormones because of the fear of causing adverse health events such as breast cancer based on false information. 2002, false information. Well, all kinds of medical specialties were either forming or getting so seriously excellent.
Right.
By 2002, menopause, which could have done that, such an interesting field, didn't do it because it discouraged healthcare. Healthcare providers all over the place were saying, I'm not going to put a woman at risk. So they just carried on with their broad-based practices, and if they treated women at all, it was a small part. So a nice short answer as I meander through the lilies and the daisies.
And those deep, deep weeds that are also in there.
All to go shopping.
Always go shopping. There is a second part to this question too, believe it or not, that we somehow didn't get to. And that is, she's asking because her doctor doesn't want to give her progesterone, I believe. She wants to know from you, do you believe that progesterone, just progesterone, not progestins, cause blood clots, as she says, as I am constantly being told? Progesterone.
Yeah. Blood clots, bioidentical progesterone. Let's go to blood clots. Here's what we know. Human beings have an exquisite clotting mechanism. There are so many biochemical steps in that clotting mechanism because it needs to be so intricate that we don't clot too easily. Otherwise, we'd be forming clots inside of our body. But if we get hit by a javelin or bit by a saber-toothed tiger, we're able to clot from the wound we get.
Yes.
So it's delicately poised and delicately balanced. And then what we know about the human race at this time in history is the delicate balance doesn't necessarily exist. There tends to be a tendency towards increased propensity to clot. It's not delicately balanced. There's an increased propensity to clot. That's in general. And when you hear about people having heart attacks or strokes, most all the time we're talking about the clot is the problem. So this is a big topic. And it's such an important topic that we devote one of our educational segments to coagulation. We're training healthcare providers and we're teaching them about coagulation and how to identify when someone has an increased propensity to clot. Now, how do hormones relate to that? Oral estrogen. Estrogen taken by mouth increases the propensity to clot. We know this. It also increases the production of certain liver proteins that relate to inflammation. Oral estrogen, taking estrogen by mouth. Not so about topical estrogen. Anyone who wants to do a deep dive in the medical literature will find this. What about progesterone? Well, here's what we know about the birth control pill. Oral estrogen plus a progestin. An artificial biochemical transformation of progesterone, so much so that they don't call it progesterone, rightfully so, they call it a progestin. We know that a certain small percentage of women who are on the birth control pill, some women, definitely got a clot, usually in their lower extremities, and if that clot breaks loose in a vein, it can travel right up to the lungs and cause something called a pulmonary embolus, and it can knock out part of the lungs. It's a life-threatening event. And this happened. And any physician who's seen enough women will hear in the medical history that, oh yes, when I took the birth control pill, I got a clot. Now what's causing that? Theoretically, it's either the oral estrogen or it's the progestin. Does progesterone, bioidentical progesterone, cause increased coagulation? Well, the only thing I can say is that I've had women that I put on bioidentical hormones, 2 of them Nancy and Denise, 25 years of specializing in seeing women in menopause. And Nancy and Denise, when I started putting on hormones, each one of them said, "Oh my, I'm getting uncomfortable in my lower leg, just like I did when I went on the birth control pill." And one of them had a deep venous thrombosis in her leg, thrombophlebitis, and the other one had a pulmonary embolus from the thrombophlebitis. Oh my, I'm taking these hormones. So what was it? Was it it was topical estrogen? The medical literature tells us that topical estrogen does not do this. Was it the progesterone? Well, I was able to oscillate into a program with each one of those that they could take hormones. So widespread fear about taking progesterone is incorrect, because if we surveyed how many millions and millions of women are on bioidentical progesterone and do not get clots, and it's not even an issue, you're talking about a very, very rare circumstance there, if at all. Now, can women get clots? Can men get clots? Yeah. So one thing we do in our intake procedure, where we give women a questionnaire that's 12 pages long, takes about an hour to fill out. It's priceless for me because I designed it, for one thing. And any physician or nurse practitioner would be very familiar with most of it. We just went into greater detail around feminine history.
Yes.
Quite a bit of considerable extra detail. We get clues. And when we get clues about coagulation, we're going to test someone, because the two major laboratories in this country, if not others, they do these coagulation profiles. They're quite expensive. They're between $1,000 and $2,000, but we can evaluate many, many parts of the coagulation mechanism. Not simple screening. We're not doing protimes and proform and activating times. That's not the only one. Fibrinogen levels. We're not doing just that. Those are valuable. We're doing an extensive coagulation profile. If you work with one of the labs, it's the venous thrombosis profile. It's got a lot to it. And if there's a familial issue there, it can be done. So I am not going to declare that oral progesterone or topical progesterone or topical estrogen biased is what we prefer in any way is something to be concerned about clots. I'm going to say don't be concerned about it. But once again, go to an expert in this. If there's a coagulation issue, we're going to find it. But how this woman got frightened, this is baffling to me. Because one of the things I do is I'm connected to a lot of folks who've been treating women for a lot of years. And if I ask them, do you think clotting is a common thing, or that topical progesterone or oral progesterone is going to do it? It's so rare it's going to boggle them, especially when you think of, like right now in America, like in 2002, there was 18 million women in menopause being treated. 40% of all women treated with Prempro. That had a progestin in it. Right now, there's probably 6 to 7 million women in the United States, not 18 like there once was, 6 to 7 are being treated with hormones, and over half of them are being treated with compounded bioidentical hormones. And how commonly do we see a clot? Hui! Extremely rare. There are circumstances in which we're going to hunker down on trying to determine whether someone has an increased propensity to clot. For example, for a woman who's been 10 years in menopause with no hormones whatsoever, we know that she's getting vulnerable to arteriosclerosis because she doesn't have the phenomenal protection to arteries that estrogen confers. So we know she's vulnerable to coronary artery arteriosclerosis. And it's like the barnacles. Picture barnacles on an artery. That is the perfect provocateur to a clot forming. Clots don't form at random.
Right. I don't
They
know where.
form when they're provoked.
Yeah.
If you get a saber-toothed tiger bite, the tissue disruption is going to be so great that the clotting mechanism that's put into place is going to be triggered. Saber-toothed tiger bite, tissue damage, clotting is triggered. Arteriosclerosis, barnacles on an artery. Ooh, trigger. That's not the nice, smooth, wonderful arterial surface that we're used to seeing. It's so smooth, and the coagulation mechanism within the bloodstream is just floating on by. Picture yourself on a tube on a warm river on a sunny day, floating on by. Oh no. When it encounters the barnacles that are very provocative to clot formation. So anyway, when you go to someone who's really experienced in this, we're going to see reasons to be concerned about coagulation. And we're going to run that coagulation profile, and we're going to put you through an echo stress test because we care about details. Yet another reason to go to someone who's, devoting their professional career to getting expert at this. This year, I have run 3 coagulation profiles.
Interesting.
That's how important this is.
Yeah.
Last year, I ran 2 echocardiograms, stress cardiograms on women who hadn't seen hormones for quite a while. I wanted to know if they had coronary artery compromise. So this is something to be concerned about. But in general, progesterone, you can buy progesterone over the counter. And that's a good thing because it does so much good, and its likelihood of causing a coagulation or thrombophlebitis is so close to nil, it's ridiculous. You can buy bioidentical progesterone over the counter. It's not a strong dose, but in a woman in perimenopause, man, I recommend it to everybody.
Mm-hmm.
No exceptions. Because a woman's progesterone is going to decline earlier and deeper than her estrogen is. So she's going to get into an imbalance. That's how it works. There's reasons why that's occurring. So if you're in your 30s and you're starting to get return of PMS, or you're getting mood stuff, you're not sleeping as well, look at happy, healthy hormones and get an assessment of whether you're getting low on progesterone, and get that progesterone. So that's the answer to the second half of the question.
Thank you very much. I just have one person that came up that said the connection is terrible, and something that we did figure out, we're in Chrome. So I'm wondering if everybody has Chrome. People who have moved over to Chrome seem to have an easier time, because I'm seeing Dr. Rosensweet perfectly. I think he's seeing me perfectly too. I'm not getting this from anybody else. So maybe Chrome might be where you want to be. Anyway, so thank you, Dr. Rosensweet, for that answer. I'm going to move on to question number 2, and that is estriol a better protector of breast, brain, and overall health rather than estradiol? And that is the question.
The answer is no. Now, caveats, 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 here they come. A woman's body, a woman's ovaries, puts out a family of hormones called estrogens.
Yes.
Also a family of hormones called androgens. Testosterone is the cleaning hormones. DHEA is one of the most prevalent prohormones or hormones that a woman puts out. She also puts out progesterone. And I say estrogens because it is a family. There's 3 major hormonally active estrogens. The most hormonally active estrogen, the most potent, is estradiol. The second most potent estrogen put out by the ovary is estrone. It's about 80% as strong, as potent as estradiol. And then the third hormonally active estrogen is estriol. It's not as potent as estradiol and estrone. It's about 1/8 as potent, or 12.5% as potent. So if estradiol is the gold standard by which we measure potency, we assign it a potency of 1, then we would assign a potency of 0.8 to estrone, and we assign a potency of 0.125, 1/8 to estriol. Now let's look at what's the major output? What's the prevalence of these things? The most prevalent of those three hormonally active estrogens is estriol.
Mm.
The second most prevalent is estrone. And the third most prevalent is estradiol. In fact, there's just a little over 2 times as much estrone as there is estradiol in a young, healthy woman. And there's more estriol than there is the sum of estrone and estradiol. In fact, studies have shown on average there's 1.3 times as much. Let's average it out and say 1.2 times as much estriol as there is the sum of estrone and estradiol. Them's the facts. That's the original design. This was determined as early as late 1960s by an oncologist, Henry Lemon, at the University of Nebraska, doing 24-hour urine hormone testing, late 60s. He came up with there was 1.3 times as much estriol as there was the sum of estrone and estradiol. And there's over twice as much estrone as there is estradiol. We repeated this. We did a study. I was funded by a wonderful laboratory named Metametrics at the time. We wanted to see what's normal for young women. We came up with 1.1. 50 years earlier, or 40 years earlier, Dr. Lemon did a 24-hour urine hormone testing, and he came up with 1.3. 40 years later, we did it, 24-hour urine hormone testing on young, healthy women in their mid-luteal phase. It was 1.1 times as much estriol. Now, why am I emphasizing that? Things happened to me in the course of my medical education that were spine tingling, tear evoking. I was so deeply moved on so many occasions as I was studying the human body. It was staggering to me.
Mm-hmm, mm-hmm.
It moved me to tears.
Mm-hmm. I understand that.
To see the level of elegance and complexity, and so far beyond my ability to get my mind around it. Just, you want to believe in the divine, study the female menstrual cycle. It'll blow your mind. What's going on there?
It's so true.
You think of your finest symphony orchestra, and there's a conductor, and the conductor is the divine herself. It's staggering. You can't even get your mind around how elegant, exquisite, and complex it is. Holy mackerel, and how interrelated, how many moving parts there are. So I've heard this from many sources, and you can interview thousands and hundreds of thousands or millions of human beings who say, look, don't try and reinvent nature. A really good job is being done here. And one of my dear friends and colleagues, Dr. Jonathan Wright, actually was teaching doctors 40, 50 years ago. Copy nature. Don't try and invent a new woman.
Right.
Don't try and invent a new human being.
Right.
Just want to do it. And this is the foundation of treating women with compounded bioidentical hormones. That you can achieve individualization that's staggering. You can deal with the complexity. So what I'm saying is, why would one want to treat with estradiol when the design is 3 estrogens? Now that may really blow your mind. My mind was blown. Every single cycle. Is this too much information, Carolyn? I mean,
I don't,
listen, we see Cheryl and Katrina and Jahira and there's others on this program right now. I'd like some feedback. Are my stories too long?
personally, I don't think so. The question is, and you get into it, well, is estriol a better protector of breast, brain, and overall health other than estradiol? I mean, really, she is wanting to know, should she just be...
I'm approaching it from the deepest science that I know. And I'm saying, well, we know how nature set it up. We know this, that every single menstrual cycle, a woman prepares for pregnancy and lactation. And if it does not occur, she unprepares. All that fresh preparation disappears.
Right.
Her uterine lining is prepared to receive a fertilized ovum. If she doesn't do it once a month, it's all cleaned out.
Yes, and starts over.
Well, one of the phenomenally interesting things to me is once a month she prepares for breastfeeding. That possible implantation in pregnancy, breastfeeding itself is prepared for each cycle.
Right.
And a woman can feel this. Many women can feel that during her menstrual cycle, about mid-cycle, her breasts are starting to get fuller, sometimes even tender. Why they're fuller, and one reason they're fuller, is there's actual additional breast glandular cells formed by cell division, mitosis. Once a month, there's additional breast glandular cells formed, as if a woman was going to get pregnant and was going to start her preparation for lactation. And if she does not get pregnant, the whole formation of those new cells is wiped out. Just like the uterine lining is wiped out, the new cells are wiped out in a process called apoptosis. I always love that name.
I do too.
These cells that formed extra breast glandular cells and had your breast get fuller disappear once a month if you don't get pregnant. So the formation of the breast glandular cell proliferation in preparation for possible lactation is under the guidance of an estrogen receptor site called estrogen receptor site alpha. Because how hormones work is there's a dance between the hormone itself and the resident receptor sites in every cell. So the estrogen comes in and affects estrogen receptor site alpha, and alpha stimulates breast glandular cell mitosis and proliferation. And if there is no implantation, the deproliferation, the apoptosis, the deproliferation is under the guidance of estrogen receptor site beta. So the second half of a cycle in an unfertilized situation is under the receptor site. It's the interaction of the estrogens with the estrogen receptor site beta, deproliferation. That's how nature does it. You want to copy nature? Well, here's some interesting information. Estrogen receptor site alpha is primarily stimulated by a hormone called estradiol. Estrogen receptor site beta is primarily under the stimulatory effects of a hormone called estriol.
Right. And so,
in other words, there's a reason when you dive as deep as you can go, there's a reason why there are 3 different estrogens. And it relates to proliferation and deproliferation, for example. Why not copy nature?
Well, Yeah, exactly. So then in your feeling to take just estriol alone, is that in your feeling, Dr. David Rosensweet, something that you feel comfortable with?
Well, I'm glad you interjected the actual question as one of your many functions with me is to keep me on track, but I'm heading there.
I know you are, but you've got a lot of fans here saying it's all good.
So, Dr. Henry Lemon, who I mentioned earlier, an oncologist, was studying the hormone profiles of women who were healthy, and that's where he came up with there was 1.3 times as much estriol as there was the sum of estrone and estradiol
Right.
in healthy women. He wanted to know if there was a profile difference in the hormones of the 24-hour urines of women who had breast cancer. And what he discovered there was a lot less estriol.
Interesting.
And he postulated that estriol was protective. Well, here's what he said. This is what I found. There's less estriol in women who have breast cancer than there is in young, healthy women. Thus, well, in the world of bioidenticals, Dr. Jonathan Wright, who wanted to see if there was an option to horse urine-derived estrogen, Premarin and Prempro, and I'm not here to diminish the beauty that was done on the planet Earth by horse urine-derived estrogen, Premarin and Prempro. Women who were treated with Premarin and Prempro were doing much better than their contemporaries.
Oh, for sure.
And what is also so about them scientifically is they were at less risk for breast cancer, heart attack, and stroke than women who are not being treated with hormones. I'm not here to diminish the power and value and gift to the human race of Premarin and Prempro. No. But I am here to say that Dr. Wright, when he was thinking, well, is there alternatives? Why don't we replicate nature? We know that pure estradiol and estrone and estriol can be, and testosterone and progesterone also exists in the plant kingdom. Why don't we have a pharmaceutical manufacturer do what they do? Because they were extracting for birth control pills plant-based precursors to the steroid hormones and doing an exquisite, phenomenal biochemical conversion to take diastogen and convert it into pure estradiol, pure estriol, pure testosterone, etc., bioidentical, identical to what the ovaries put out. And Dr. Wright had this outrageous postulate: why don't we just copy nature and treat women with how nature does it? And he started out with Triest, but on 24-hour urine hormones, he realized he didn't need to supply the estrone, that the body would do it. So he invented this thing called Biest. Well, he didn't invent it. Nature invented it. Biest. And a very common starting dose for Biest is 80% estriol.
Right.
80%. 80%. You want to replicate what a young woman's hormone distribution looks like? You start out with Biest and you do 80%. And I'd say 75% of my patients wind up on 80%.
Yep.
Start off on 80%, wind up on 80%.
Yep.
Some women need changes, but you should only make those changes if you do the 24-hour urine hormone test. So copying nature has you throw in 80% estriol, 20% estradiol, and you'll replicate a urinary hormone profile that looks like young women. Not the levels. We don't need young women levels. Young women have between this much and this much estrogens. Some women can be perfectly healthy with a low amount of estrogens. Some women are perfectly healthy with a rather robust amount of estrogens. The range between woman to woman is very huge.
Yes.
But what menopausal women need, 90% of them, is right below that. It's right below the lowest. They don't need breast glandular cell proliferation. So if young women are at this level of estrogen, some are at the low end, some are at the high end. Menopausal women, 90% of them need below that, because this level in some women will cause breast glandular cell proliferation. We don't want it.
Which you don't want.
And
No.
we can get almost all the necessary benefits and crucial importance of estrogen by coming in below it.
Got it.
Now I say 90% or some percentage because there are exceptions, and it's those with cognitive issues. And sometimes women with cognitive issues really need a small, medium, large, or huge amount more estrogen than women who do not have cognitive issues. So that's a whole other story. But estriol, there was a time in hormone treatment history that in Japan and Europe, I'm told, that a lot of women were being treated with pure estriol.
Mm-hmm.
One could be tempted to do that. But what I found in my practice is estradiol is also a human hormone.
That's a combination of both.
So the combination is what produces the best results. And in fact, you try and invent your new nature. Let's invent new nature. We don't think that the original design was that cool. Let's invent a new woman. Let's just give her estriol because we think that's a good thing. No, that's why I take us back to copy nature. Estriol, and I'm going to flash this up just to boggle your mind. Da, 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 da. This is the biochemistry of estrogens, truncated, but and if you give too much estriol, you're going to cause, by the law of chemical mass action, a backup. You're going to get an increased 16 alpha. Ooh, that's not good. An increased estrone. It's the chemical law of mass action. So I do not give pure estriol because I can see in a 24-hour urine when we're messing up the normal biochemistry. And we're creating increased 16 alpha. That's not favorable. Or we're increasing estrone just because we gave too much estriol. So although some women, most women, 100% of our women, we start them out on 80%. For some women, that's a bit too much estriol. It'll back up the biochemistry. It'll create a non-copy nature situation. So we copy nature. We just move towards what nature did, and we'll change the percentage from 80-20 maybe to 70% or 60% or 50%. I have one patient who's on 20% estriol, 80% estradiol. That's very rare. Usually, if we're going to change it, we change it according to the 24-hour urine hormone test. Nobody should be messing with that ratio unless they're looking at a 24-hour urine hormone test. So there we go.
Yeah, well, it's once again, it's an excellent answer. It is. It's a lot to digest, but we get there. We do, and that's why the beauty of the repetition. We retain things through repetition, and you're so good at doing that. Something came up.
One thing that illustrates is, best case, go shopping.
Yep.
Connect up with someone who's devoted their professional life to this.
Absolutely.
Having said that, so many women are going to do so well. 1 or 2 doses of Premarin or Prempro did so much good for women, millions of women. Yeah. But we're talking about our health here. We're talking about the health of your vagina, your bones, your muscles, your brain, your arteries, your skin, your hair, your libido, your cognition. Oh God, these are critical functions that you want to have firing on as many cylinders as you can keep going. Because I can tell you, having worked with women in their 80s, in their 90s, and you've heard me say this many times, and I know it really landed with you, Carolyn, that someone's life is important. When you're going to be 80 years old, when you're going to be in your mid-70s, you're going to be 80, and you're going to be in your 90s, your life is going to matter to you as much as it does right now in your 40s. And it's even going to be more important. Your health is going to become more of an issue, and it's going to be more crucially important to you. So the moral of the story is always the same. If there's one thing I hope arises from this Facebook Live that we do twice a week, is that you get inspired to seek out an expert in treating women in menopause with compound and bioidentical hormones. And you get dialed in at a level of expertise that is really excellent. And then once you're dialed in, it doesn't change that much year after year after year.
Right. And it's year after year after year, because we take them the rest of our lives. And, you know, who doesn't want to have a great life? You know, that's why the doctor shopping is so important, and hooking up with that professional that's going to take this journey with you. And I don't want to get all worked up, but I will. I want to ask a question that I forgot about the progesterone. Please ask about the progesterone gel capsules versus compounded powder progesterone capsules. Is there a difference?
Yeah, there is, and we've got 3 minutes.
I know, so that's why I thought maybe I'd throw that one, and I've got
throw it at me, eh?
Yep.
Here's what we want in the world of progesterone: micronized, bioidentical, compounded progesterone. That's what really matters. Now, there's a couple ways to take progesterone. Unique among steroid hormones, progesterone can be taken topically, like all steroids can. Progesterone can also be taken orally. Not so for estradiol. That's not the best case. And absolutely not for testosterone orally. But progesterone can be taken orally. And again, the progesterone you want is micronized, compounded, bioidentical. Now, there is a commercial progesterone available. It's only available in 2 strengths, 100 milligrams and 200 milligrams. And if it was the only tool I had, I would use it. But it's in peanut oil, and it's got some dyes in there, and it's in peanut oil. Why they use oil is these hormones are not water soluble. You can't just put them in a tablet.
They sink.
So I'm a fan of bioidentical, pure, molecularly identical, compounded, which can be put up dry. It can be put up in oils. Some compounding pharmacists put it up in oils. I prefer when we're going with the oil, with the oral, with the dry micronized orally, and it has special sleep benefit. So when we're not succeeding with sleep, we'll go to the oral. There's an estrogen component to sleep disturbance, that's for sure. But if between estrogen topically and progesterone topically, if we're not fully dealing with the sleep, we're going to move to oral. And I'd say 50% of my patients, we wound up on the oral micronized progesterone. And so that's what you want to know. In state of the art, like what we do is we give women, when we're switching to the oral, we give women 2 bottles, 30 capsules of 50 milligram progesterone, compounded bioidentical progesterone in capsules, and 25 milligrams, 30 capsules. And we start most women on 50 milligrams, and then we'll have them increase gradually to 75, 100, 125. We're once again having women find their own dose. Some women need 25 milligrams. There's occasional women will start on 25 milligrams. I've had women who have needed 5 milligrams, 1 milligram. Very rare. Most of my patients come in somewhere between 50 and 125 milligrams. We like to go for the detail.
Yeah, oh, yes. Well aware. And I know you have like 3 seconds, but that would be, she could go and ask her doctor, please, may I have the compounded powder P capsule?
Easy. Compounding pharmacies are doing these all the time.
Right. Okay. So I think that
Jim Hunter is on this call.
he is.
If he is, confirm, Jim. Is that can you just as easily compound powders as you can put progesterone in oils?
Well, he'll get back to us.
You can your physician can write the prescription to a compounding pharmacy.
Yes, and they know. And
they know how to do it.
Right.
This is their bread and butter. And
right.
Oh my, Carolyn Shapiro, we're on our way to completion today.
We are indeed. And I have a few questions left, and I have these questions here, and I'm going to have a field day for sure. And I will get those to you, and we will get them answered. Wishing everybody a really fabulous few days. And it'll be nice to see you again on Tuesday. Dear Dr. David Rosensweet.
Dear Carolyn Shapiro, thank you very much.
Yeah, and to all the women and men, God bless. Everybody have an amazing, amazing weekend, and we'll see you later.